For more efficient delivery of oxygen, the deoxygenated blood from the SVC alone is presented to the lung for oxygen uptake. The admixed blood inside the ventricle is not present to the lung. Only the SVC blood goes to the lung. The net result of the more efficient oxygen uptake in the lung is a reduction in cardiac output needed to achieve a given oxygen delivery. You can compromise in cardiac output, but more SVC blood has to go into the lung and PA for efficient oxygen delivery. And here, ventricle filling is not absolutely depend only on pulmonary venous return, because the IVC blood is still directed to the ventricle. Apart from the pulmonary venous blood which goes into the single ventricle, your IVC blood is also diverted to the single ventricle. So, it maintains the preload. As a result, the acute volume reduction is noted after superior cavopulmonary anastomosis is better tolerated. Only one half of the venous return goes to the lung, other half is still coming to the ventricle. So, the patient is in a transition phase for Fontan. So, when you do the completion Fontan, the child tolerates without any major hemodynamic disturbances. So, this is the SVC which connects to the right pulmonary artery. If the pulmonary artery is of adequate size and the PVR is low, there is a good pulmonary flow and your saturation will be good. If the pulmonary artery is hypoplastic or your PVR is high, lot of MAP cause with additional blood flow, your Glenn flow will be reduced. Here, the saturation will be low. So, high PVR, hyperplastic pulmonary artery, additional MAP reduces the saturation. Low PVR and a good size pulmonary artery helps in maintaining the saturation following a Glenn. Now, coming to the saturation, your SVC, which is the deoxygenated blood, which is more than the IVC, comes into the pulmonary artery, and your IVC is little bit better oxygenated than the SVC, which is around 60%. This 50% goes into the pulmonary artery. Pulmonary artery saturation will be 50%, and this goes into the lung and comes into the left atrium as oxygenated blood, which is around 90%. Then, due to admixture with the venous blood, which is IVC blood, which is 60%, this 60 plus 92 will be somewhere around 85% in the left ventricle, and this 85% goes into the systemic circulation as 85%. This is the saturation usually happens in the postoperative period following